Welcome to the 2020 Community Forum. This is the Dystonia presentation. I'm Jen Lyman, and I'm so pleased to introduce Bhooma Aravamuthan, and she will be presenting Understanding Dystonia, Diagnosis and Treatment. Dr. Aravamuthan is an assistant professor of neurology and a pediatric movement disorders specialist in the Cerebral Palsy Center at St. Louis Children's Hospital and at the Washington University School of Medicine. She completed her research doctorate at the University of Oxford in England, medical school and pediatrics residency at Washington University in St. Louis, and child neurology and movement disorders fellowship at Boston Children's Hospital and Massachusetts General Hospital, before returning to Washington University as faculty. She leads the Cerebral Palsy Research Network Committee on Dystonia Quality Improvement, founded and directs the Child Neurology Society Cerebral Palsy Special Interest Group, and is vice chair of the American Academy of Neurology Intellectual and Developmental Disabilities Section. Her research on objective dystonia diagnosis methods has been recognized with early career investigator awards from the Child Neurology Society and the American Neurological Association. Thank you so much, Bhooma. We are thrilled to have you here presenting, and I can't wait to see what you have to offer. I really appreciate all you're doing.
Thank you so much. I'm excited to have been asked. I'm really excited to talk about this topic, which is near and dear to my heart. So, like you said, my topic is on understanding dystonia, both its diagnosis and its treatment. Just to go over disclosures, none relevant. The focus of this talk is specifically dystonia and cerebral palsy, which is my particular research focus as well, because cerebral palsy is by far the most common cause of dystonia in childhood. And because the other more rare causes of dystonia, the appearance and management of those other types of dystonia really differ depending on what the specific cause of the dystonia is. So I'm focusing now on the most common cause of dystonia overall. So what is dystonia? It is one of three different types of high tone, and all of these types of high tone can occur together. In CP, rigidity is not seen. And in fact, rigidity is not seen very commonly in childhood at all. So I won't be talking about rigidity much further. But we do see a lot of spasticity and dystonia in both children and adults with CP. And it can be very hard to differentiate between them, and they often show up together in the same person. So spasticity is present all the time to some degree. It can vary in how severe it is over the course of the day or depending on what the person is doing, but it's always there. And it's not triggered by voluntary movement. So someone who has spastic tone, high tone in their legs at rest is going to have comparable degrees of high tone when they're walking in their legs. In contrast, dystonia is very variable. So it's classically, with rare exceptions for very specific causes of dystonia, it's classically absent during sleep. So if you have a child or a person with CP who has really high tone when they get worked up, or really high tone when they're trying to do different things during the day, but at other times is very loose, very floppy, has very low tone, and tends to be very loose when asleep, that is much more characteristic of dystonia than it is of spasticity. Dystonia is also triggered by voluntary movement, meaning that you may not have high tone at rest, but then when you're trying to make a movement, you see that high tone acts up and you get these abnormal, what can often be very painful twisting postures. And one of my patients described their dystonia to me as them activating muscles when they didn't mean to, which I think is just a really cool way to describe what triggered by voluntary movement means. So this is the actual formal definition of dystonia that tries to wrap up everything I just said in a tight package. But maybe reading this definition, you can appreciate how it's very hard to describe to someone with words alone what dystonia can look like and why it might be hard to diagnose. So it's characterized by muscle contractions that are abnormal, can be repetitive, their movements, their postures, it can be both. So just because it can appear very differently depending on the person or the type of movement being done, it can often be hard to identify. So this is the classification of different types of cerebral palsy. And I bring this up because the key features that I think can differentiate or help differentiate between spasticity and dystonia on history are key features of trying to classify those types of high tone in this classification system for trying to figure out what is the predominant form of tone in someone with CP. So the key questions here are, is there persisting tone in one or more limbs, or is the tone varying? And based on whether those are present, you can fall into a spastic cerebral palsy bucket or a dystonic cerebral palsy bucket. And this 85 versus 15% is kind of how we classically think of those buckets being divided, that 85% of people with CP tend to have predominantly spasticity, 15% of people with CP tend to have predominantly dystonia. But the more and more we're learning about people with CP, the more we're realizing that these, we can't really put people in a bucket, right? That people often have both forms of high tone, and this, it's really a spectrum, it's a continuum between those that have predominantly spasticity and predominantly dystonia, and the vast majority of people have both. So just to speak to that, dystonia is much more common in CP than I think we give it credit for a lot clinically. So this is a study from Darcy Failing's group using a tool called a hypertonia assessment tool that I'll talk about a little bit later, showing that, and this is a modified Venn diagram, and the circles represent the groups of people that have dystonia, groups of people that have spasticity, and the group of people that doesn't have this form of high tone, either form of high tone. And you can see that the spasticity and dystonia circles overlap almost completely. So at least in this study, almost all people with spasticity also had dystonia. And that doesn't necessarily mean their dystonia is their predominant form of high tone. It could have been very subtle. But because dystonia shows up when you're trying to make a movement, even a little bit of dystonia can have very large functional effects in how you move. So the idea of categorizing people as predominantly dystonic or predominantly spastic, I think, is less important than figuring out what type of tone and where the tone is that's making you the most functionally impaired. So to speak to dystonia having a huge functional impact, there have been several studies that have come out in the last few years talking about pain associated with dystonia and the functional limitations associated with dystonia. So we've long known clinically that people that have dystonia tend to have more severe functional impairment than people that don't have a lot of dystonia. And I think the quantification of pain is emerging more and more, particularly in people with dystonia. So 90% of those with severe dystonia, and these are people that were considering candidacy for surgical treatments for their dystonia. So 90% of those people reported moderate to severe pain specifically from their dystonia, which is a huge number. Those with dystonia say that over 50% of the time they can experience pain, and that pain can disrupt their activities. And then specifically looking at function, including the gross motor function, speech, and fine motor function, manual function. Over 50% of people with dystonia and CP had the highest limitation levels, meaning that they were maximally limited of these systems allow for classification in both gross motor function and manual ability and speech. So just thinking about that, addressing dystonia is a critical problem in this population. So unfortunately, and as I alluded to earlier, even though it's really important for us to address dystonia, it can be very hard to identify who has it, which seems like this odd sort of catch-22. So this is from our center, which is a tertiary care center, St. Louis Children's Hospital, affiliated with a top-tier medical university. And I say that because even in our center, we found that there was difficulty in identifying or differentiating between spasticity and dystonia in a high-risk population for CP. So this was over a 5-year period of follow-up of children that had hypoxic ischemic encephalopathy, so evidence of brain injury around the time of birth. And they were followed for the next 5 years. And then just looking at documentation from neurologists who followed them, only a small percentage of them, by the time they were 5 years, had their hypertonia classified as spasticity, dystonia, or both. And it just speaks to how hard it can be, particularly in young children, to tell who has spasticity and who has dystonia and who has both. So this tool, the hypertonia assessment tool, which was developed by Darcy Failings and others, really tries to address that problem by giving people a codified or a listed, very clear-cut set of rules for how to differentiate between dystonia, spasticity, and rigidity, the other form of high tone that we don't really see very often at all. Using this tool can be a huge benefit to putting dystonia on the radar of clinicians and making sure that they're looking for it in a rigorous and systematic manner. The problem is that even when you're looking for it, dystonia can be really subtle and it can be very hard to pick out by eye. So to speak to this, this is a study from our center where we look to see amongst movement disorders specialists. So we're all folks that had been fellowship trained in recognizing movement disorders, and dystonia is definitely one of the movement disorders that we're trained to recognize. So we evaluated a set of 40 videos of children with CP walking. So these were all children that were independently ambulatory, but independently walked who had CP. And we looked at how, just looking at the video visually, how well could we identify dystonia? And more than that, how much did we agree with each other? And we discussed, so we classified the video, then we discussed, and then we reclassified to see if we would change our opinion depending on what other people said. And across varying levels of seniority here, one person in this list has 15 plus years of experience as a movement disorders attending. There was a comparable level of quote unquote flip-flopping, where after another person pointed out something that they saw in the video, you then saw the dystonia that another person may have been able to pick up subtly. Or after another person pointed out that maybe what you were seeing wasn't quite dystonia, you then thought, okay, well, maybe they're right, and then changed your vote. So even amongst these experts, dystonia can be hard to identify in videos. And moreover, at the end of all of this discussion, looking at videos, just by looking at video alone, there were 6 out of the 40 videos where we didn't reach unanimous consensus, meaning that at least one of us disagreed with, or meaning that one of us disagreed with the other 2. So again, it just goes to show maybe in a clearer way what we had already assumed, that dystonia can be very difficult to visually diagnose. So here are some of the example videos that we looked at. And I'm just going to let them play so you can see what these walking patterns look like for each of these patients. This first set of 2 videos, we reached unanimous consensus on both of them. And they may be a little more obvious to everybody who's watching, but this patient did not have dystonia in this video, does not have any dystonia otherwise on clinical exam, but does have a milder degree of spasticity in her legs, in this leg more than this leg. And then this child does have pretty significant gait dystonia and dystonia in her hands as well. Although the hand dystonia is a little less clear in the video, but hopefully the gait dystonia is clear, where you can see over the course of gait, over the course of walking, her feet are turning variably inwards, and her legs are coming in variably as well. So that abnormal movement triggered by walking, which is a voluntary movement that's variable over time, so that changes over the course of her walking, is very characteristic of dystonia. But then here were two videos where we could not reach unanimous consensus. There's one, and then here's the other one.
Yeah. Well,
so just to talk about where the controversies were here, oops, sorry, let me go back. It was unclear to us whether in just looking at this one video, this foot of this child did happen to go variably in the middle of the video. And it was unclear to us whether that was a dystonic movement or whether that was something more voluntary. And in this video, this young lady has her foot turned in on this side throughout the whole video. And that is classically, it's an abnormal movement, but it doesn't vary over the course of the video. So for both of these kids, we couldn't make a distinction of whether or not they had dystonia based on this video alone, meaning we needed some more data, some more history, and some more exam maneuvers to be able to figure that out. So this isn't to say that 15% of the time we cannot diagnose dystonia, but it is to say that you can't diagnose dystonia maybe even in a single visit or in a single setting or with a single exam maneuver. It requires a comprehensive assessment. So to help make the process of dystonia diagnosis a little bit easier, we've been working on using some machine learning techniques, some supervised machine learning techniques to identify key parts of the body in patient videos that can be easily videotaped in a routine clinic visit. So these are just smartphone quality videos of kids and young adults walking down our clinic hallway. And we wanted to see if we could identify some key features of dystonia that made clinical sense to us, that could also help differentiate between groups that we said were clearly displaying dystonia, so kids that clearly had dystonia in the video, so by unanimous consensus, and kids that did not. So there were a few gait variables, inter-knee distance variance, the difference between foot angle between the limbs, and foot angle variance, which are all measures of how much movements differ between limbs and how much movements differ over time. And with all three of those variables, we saw that there was significantly more variability in groups that we identified as having dystonia, or videos that we identified as displaying dystonia compared to videos that did not. And by taking all three of these together, we could, without any physician or human input per se, could identify, using this algorithm, expert characterized dystonia 93% of the time. So what does this mean? It means that maybe there are objective screening algorithms that can be applied to videos that we can acquire in clinic that can be used to screen for dystonia. It may not be able to replace the thorough and good assessment of a physician or another caregiver who's expert in care provider who's expert in dystonia diagnosis, but it can help identify kids that may have dystonia that would require maybe referral to someone, to a dystonia expert, if the person evaluating them in the room doesn't feel comfortable with their dystonia expertise. So I'm hopeful that techniques like this could be further developed to help improve dystonia diagnosis. So we've gone over dystonia being common, dystonia being functionally very limiting, dystonia being hard to diagnose. Dystonia is also hard to treat. So this was an incredible systematic review that was published very recently, talking about the availability of different, or the efficacy of different treatments and the evidence for efficacy of different treatments for dystonia. What is, I suppose, disappointing is the word to use, is that there isn't a lot of great evidence about the treatments that can be used for dystonia. And of the oral medications that are commonly used, Artane or trihexyphenidyl being one of the most common medications, there is limited to possibly negative evidence that it is helpful for dystonia and in cerebral palsy. And we do know that it comes with quite a few side effects. There are two other medications that don't really have a lot of great prospective data in dystonia and CP, clonidine and gabapentin, that are increasing in popularity for their use for dystonia. And anecdotally, I think many of us have seen great effects, particularly for pain and mood, noting that mood can be a trigger for dystonia as well. But we do need studies looking at the effects of clonidine and gabapentin in a prospective and ideally controlled manner to see what the effects of dystonia and CP are. The best evidence we have is surprisingly on surgical treatments for dystonia, which are typically considered really only for severe generalized dystonia. And the two types of treatments that have been looked into are intrathecal baclofen and deep brain stimulation. So I think we more commonly think about intrathecal baclofen pumps in the context of spasticity. When we think about the catheters being implanted lower in the spine to address spasticity in the legs. But for intrathecal baclofen implants for dystonia, the catheter is typically placed high in the spine. And there have been two good prospective studies showing improvement in dystonia scales with intrathecal baclofen. I think there's been some limitation in its use because of fears of side effects and because of fears of placement, knowing that it is in the high cervical spine, which I think makes a lot of people nervous because that's, as we say in neurology, it's high quality real estate, the cervical spine, meaning that we don't like messing with it if at all possible. And also because of the side effects and potential for complications for intrathecal baclofen pumps in general. However, when done and when tolerated well, intrathecal baclofen pumps do seem to provide good improvement in generalized dystonia. Deep brain stimulation is a treatment that's really becoming more and more common in the last decade. In children and to a large degree in adults, the implantation is restricted to a specific part of the brain called the globus pallidus pars interna. And that means that in order to be a candidate for DBS, that part of the brain should be relatively uninjured. So an MRI showing an intact, that region of the brain intact is important before undergoing DBS. And there have been several trials looking at the efficacy of DBS for dystonia. Half of them showed improvement. 2 of them didn't talk specifically about dystonia rating scales, and then 4 of them did not demonstrate a clear dystonia reduction. Interestingly, thinking about what these trials have looked at, many surgical trials focus on dystonia rating scales, and specifically looking at a clinician assessment of how much dystonia the patient has. And very few of the studies have rigorously assessed the effects of dystonia on function, quality of life, and this study in particular that I pulled this quote from was also interested in choreoathetosis, which is a type of fast movement that can be associated with dystonia in some children. So that's unfortunate, obviously, because subtle dystonia may not be affected by very many treatments and may not show up on as a change on dystonia severity scales. But decreasing someone's hand dystonia in their dominant hand could have dramatic impacts on function. So really focusing on the functional impact of treatments is something that's becoming, is research that's becoming more and more common. So this is a study from DPhil's group in London, looking specifically at deep brain stimulation and pain. So this came out very recently, this year. And they showed that in children with CP, that pain was significantly reduced, both on a variety of subjective pain scales, both discussing with the caregiver and the person undergoing DBS, and also when looking at the amount of analgesia that was used. So how often was the person taking pain medications to deal with their pain? So I think studies like this are happening more and more and are much more critical to figuring out what treatments we should really be pursuing for dystonia and CP. So to summarize, we still need to do a lot of research on all of these topics, but I think that the focus on doing rigorous research that's functionally targeted is increasing, and I think that's a really positive thing. I think that trials looking at intrathecal baclofen versus deep brain stimulation, whether the benefits are additive, which populations of children and young adults with dystonia might respond better to ITB versus DBS, those sorts of studies should happen. And other oral treatments like clonidine and gabapentin need to be studied prospectively as well. And I think I'm biased because this is what my research focus is on, but treatment and management is incredibly important, and that's what will get us over the hump to improving function in people with dystonia and CP, but we can't treat dystonia without diagnosing it. So I think one of the critical and maybe primary efforts that research and quality improvement initiatives need to focus on is making sure that we're diagnosing dystonia accurately and diagnosing it in the context of where it's causing functional impairment for our patients. So with that, I am really looking forward to taking questions, and I invite everybody in the audience to contact me with questions about dystonia. So thank you.
Bhooma, this was amazing. I could talk to you all day about my son and dystonia. And we do have some questions from the audience. I had a couple questions that came up as you were presenting that I wanted to go ahead and ask. Does dystonia get worse with age?
Great question. So we, surprisingly, we don't know. So there is, anecdotally, some people say yes, some people say no. There are case reports of children that had had brain injuries around the time of birth who did not manifest dystonia for up to a decade after the initial brain injury. And there often is a delay from initial injury to dystonia onset. We really need to characterize people as they age, people with CP as they age, both in the context of spasticity and dystonia, to really be able to answer that question. I can tell you that my gut tells me that it probably does get worse with age, and there are probably people with dystonia that didn't have dystonia early in life that then develop it later on, but I can't back that up for you. So we definitely need to look into it.
Thank you. And with the HAT tool, is that something that if it was available to parents, we could look at and kind of say, hey, you know, my child exhibits these things, and take it to our physicians and say, hey, this is, you know, this is what I'm seeing?
I love that question. So let me see if I can go back to the hat tool. So when the hat was developed, it was developed including questions that were, including history questions. So questions that were specifically meant to be answered by caregivers. And those questions were things like, is your child's tone variable? Are there times when is your child loose when they're asleep? Are they tighter when they're awake, or when they're stressed out, or when they're making a voluntary movement? And I'll tell you that in the clinic, I ask families that all the time as a way to help me diagnose dystonia. So my bias is that yes. So if you do see those things in your child, you can say to your clinician, I'm worried that my child has dystonia. These are the things I've observed. When developing the hat, people found that those questions caused a lot of confusion when they were asked out of families, and that because spasticity can also be subtly variable over time, over the course of the day, it ended up, a lot of caregivers ended up confusing spasticity for dystonia. I guess what I would say is if there are moments during the day where your child or the person with CP that you're caring for is truly loose, and there are times when they're truly tight, that is dystonia. If there are times when they have high tone, but sometimes it's a little bit worse and sometimes it's a little bit less worse, that could be dystonia, but it could also be spasticity. So in the scale, all of these yellow boxes talk about exam maneuvers to do for dystonia. So I think that's probably much harder to ask a caregiver to do. But that's I guess the history of why history questions aren't specifically included in the hat.
I understand. I'm going to take some questions from the audience for you. One of the when you were showing the graphs of the children using the machine learning, and one of the comments was, "Wow, it's such a marked difference." One of the questions we had was, "Can that be used with GMFCS 4s and 5s? The same kind of tracking?"
It can, yes. So this initial study we limited to children who were just independently ambulatory. But if the same sort of tracking algorithms can be done for any sort of motor task for children with any functional level. So that's the goal. The goal is to generalize this to everybody with CP.
Okay. And then Michelle had a question. What are some reasons someone would want to know if an individual with CP has dystonia?
Yeah, so great question. So the treatment options for dystonia really do differ from the treatment options for spasticity. So just thinking about ITB, intrathecal baclofen, and deep brain stimulation options that I discussed at the end of the talk, neither of those are indicated for a child with predominantly spasticity. So, and both of those treatments can be helpful in very specific ways. So it's very important to identify whether your child has dystonia for treatment and management purposes. In a separate category, I think it's also really important to identify whether your child has dystonia to understand why they have CP. So there's a great study from Canchild that came out, I think, a year ago, talking about children with dystonia having different etiologies, different causes of their CP, and maybe some causes that might look like CP but aren't CP at all. So I think identifying dystonia in someone, in a patient, can really help identify what's causing their overall motor impairment as well.
And then I think to follow up that, if a parent is concerned or curious that their child has dystonia, what should they do? How should they bring that up with their physician?
Yeah, I think saying to your physician, I think my child has dystonia. I've heard about dystonia. I think this is, these are the things I'm seeing that make me worry about it. And if I think many physicians have some discomfort in identifying dystonia themselves, and I think that's fine. But then asking for referral to someone who's more comfortable identifying dystonia, maybe at a cerebral palsy center, or maybe at a larger center where kids with dystonia are seen more commonly.
Got it. From Angela, she writes, this really hits close to home. Took years to obtain this diagnosis for my daughter. Would a select treatment such as Botox help to control dystonia to a certain point of her body? For example, to stop her foot from turning in?
Yeah, great question. Yes, it can. It depends, I think, on it depends on the person. So there are some kids that have a lot of dystonia in a specific limb, but when they don't have dystonia, the arm or the foot is really loose and really floppy. And in those children, I think Botox can be a little counterproductive because you want to be able to maximize their strength and their ability to use the arm, the hand, the foot, even when it's loose. So if, on the other hand, if your child, most of the time you see that their hand is turned in or their foot is turned in, and it's really limiting their ability to use the hand or the foot at all, then I think Botox can be really helpful. And I think deciding on that treatment really has to be a detailed discussion with your providing medical caregiver to talk about what are my goals for Botox and what are my goals, period, functionally, and will Botox help me achieve those goals?
Let's see, this is actually similar. I believe this is almost exactly the same question I asked earlier. The presence and extent of dystonia, let's see, whether the present and extent of dystonia is present and fixed at birth, or can dystonia and the extent thereof change over time during development? That is, if a child does not have it at birth, can it develop afterwards, or if they do, can it get more or less severe? And I think we covered that a little bit, but
yeah, I will say that it is that's something to think about for dystonia is if it's present immediately at the time of birth, so within days of birth, let's say, I would want to make sure that that child has had a workup for some disorders that can mimic cerebral palsy, like neurotransmitter disorders, for example. But it is very common in cerebral palsy of many different causes, including genetic causes, including birth injury causes, to have dystonia show up at least a few months after birth. So that isn't, I think, a direct answer to that question, but I want to make sure that that distinction is clear.
Getting to the intrathecal baclofen versus the DBS. So our family has had a rough time with intrathecal baclofen. And I'm curious what the difference is in the effects of the two options. For somebody who maybe didn't do so well with intrathecal baclofen, would DBS maybe be a better option? And how does that differ?
Yeah, so I guess it depends on a couple of things. So if the issues with intrathecal baclofen were mainly associated with side effects and complications from the intrathecal baclofen, then I think it's very possible that deep brain stimulation could be something that's worth trying, as long as other criteria are met, meaning that part of the brain that I talked about is intact. And meaning that there's a good understanding of the functional implications of DBS, meaning you may not see a clear reduction in dystonia, but if pain is a big issue, if comfort is a big issue, then those things may be improved with DBS. There have been some studies comparing DBS and intrathecal baclofen, but they've all been retrospective. So it's hard to say which is which population of children or young adults with CP would benefit from one versus the other.
So I guess I'll just have to call you.
Yeah, I guess so. Just call me.
And come visit you. Okay, I've got another question for you. This is from Lynn. My daughter has dystonia that is not severe. She doesn't complain of pain. She has taken levodopa for years for it, and it does seem to help some. Would more invasive treatments ever be recommended for a mild case to achieve improved function, or are the more severe cases usually targeted?
Great question. So right now we're only thinking about DBS, at least for more severe cases. As a disclaimer, at my center, we're not doing intrathecal baclofen for generalized, for severe generalized dystonia. So I can, just in my experience, I'll talk more about DBS. For subtle, or subtle may not be the right word, but for dystonia that's maybe more focal and quote unquote manageable, I find that category may be the hardest to treat, to be honest, because it's very difficult to find a medication that's systemic that focuses on treating dystonia in one hand. I think that depending on what's going on, Botox could be an option for more focal dystonia. I'm glad that levodopa has helped some. There are other treatment options that could be tried depending on the triggers for dystonia. So if mood is a big trigger for that person's dystonia, then clonidine may be an option to try, for example. But the surgical treatments, I think at this stage at least, are really reserved for more severe generalized dystonia.
All right, let's see if we've got any more questions. Does anybody else have any more questions for Dr. Bhooma? I've been so amazed. This is just such a wonderful presentation, and it's so helpful. I keep giggling. I was like, we've tried Cinemet, Artane, levodopa, the whole gamut, and it's such a complicated issue, and you just do such a beautiful job explaining it to families. And I'm really looking forward to being able to present this on the Academy's website and for all the families to see it. And thank you for preparing such a wonderful presentation today. I'm so grateful.
Yeah, it was a pleasure to be here. Yeah, I hope we can do better in the future and make sure that we push our research agenda forward to help our kids and help everyone with CP and dystonia.
Well, you're leading the pack. That's for sure. Thank you, thank you, thank you.